Our next speaker is Dr. Kristen Sullivan. Kristen is a research scholar in the Center for Health Policy and Inequalities Research here at Duke. She got her PhD from the School of Public Health at UNC. She studies factors affecting the engagement in HIV care in women and adolescents. And today she's going to talk to us about the contribution of 5 psychosocial factors contributing to the achievement of viral load suppression as a marker for accessing HIV care. The title of her talk is SAVA Syndemic Effects on Viral Suppression Among HIV-Positive Women of Color. Kristen.
Okay. Great, thank you. All right, thank you, and good afternoon. Women of color are disproportionately affected by the HIV epidemic in the United States. 24% of the U.S. HIV population are women, and compared to white women, HIV infection rates are 20 times higher for Black or African American women, 4 times higher for Latinas or Hispanic women, 3 times higher for Native American and Alaskan Native women. Also, the AIDS rates are disproportionate as well, 23 times higher for Black African American women than white women, 4 times higher for Latinas, and twice as high for Native American and Alaskan Native women. So, and in addition to having an increased risk for infection, they are also at increased risk for mortality and being lost to care. Research has documented the clustering of substance abuse, violence, and HIV/AIDS among marginalized groups, which is referred to as the SAVA Syndemic. Mental health problems and sexual risk behaviors are also often included in this framework. A syndemic approach to health disparities directs us to consider the excess burden of entwined and mutually enhancing health problems, fueled by social and economic inequities. And this approach also suggests that we should be focusing on common risk factors through more holistic interventions. Though the SAVA-related psychosocial problems have been widely studied among HIV-positive women in the U.S., and some research has looked at SAVA effects on mental health, few studies have directly tested the models among this population, and there is a lack of research examining SAVA effects on viral suppression among women of color. Prevalent psychosocial problems can create barriers to achieving viral suppression among HIV-positive women. These factors may negatively affect health outcomes in myriad ways, including decreased engagement in HIV care and reduced adherence to medications. Approximately 55% of women living with HIV or AIDS have experienced intimate partner violence. A history of trauma, abuse, and violence for HIV-infected women is associated with decreased medication adherence and increased viral load. Studies consistently document a high prevalence of mental health disorders and symptoms among HIV-positive populations, of which depression is the most consistently associated with decreased adherence. An estimated 8% of HIV-positive people in the U.S. abuse alcohol, while 1/3 of HIV patients receiving care report active drug use. Both alcohol and drug abuse are associated with poor ART adherence and viral suppression failure. Findings have been mixed about the association between sexual risk-taking and antiretroviral treatment, though a 2004 meta-analysis of 12 studies examining the association of unprotected sexual intercourse, or STIs, with having an undetectable viral load found no association. These psychosocial problems frequently co-occur among HIV-positive women of color, potentially compounding the risk for poor clinical outcomes. The application of the SAVA framework to viral suppression among women of color demonstrates how the intersecting epidemics of substance abuse, binge drinking, intimate partner violence, mental health problems, and sexual risk-taking, and HIV/AIDS combine to impair health. Further, it may help elucidate the complex relationships between psychosocial and health problems in order to inform effective interventions. So the purpose of this study is to assess the utility of the SAVA Syndemic approach for understanding viral suppression among HIV-positive women of color in the U.S. The data for these analyses was taken from a special project of national significance program, the Women of Color Initiative, through the Health Resources and Services Administration. It happened from 2009 to 2014. 10 sites were included in all regions of the United States. The eligibility for participation was determined by self-report of being non-white, female, or transgender female, not currently in HIV care. Participants were recruited via outreach to newly diagnosed women through HIV counseling and testing, or through site outreach to clients who had not participated in care in the last year or had been lost to care for more than 1 year. So baseline surveys, which is where this data was taken from, were conducted at the 10 sites, assessing demographics, barriers to care, and behavioral risk factors. Chart abstractions were also conducted, which were the source of the viral load information analyzed. Mental health distress was measured through a question taken from the health-related quality of life measures from the CDC Behavioral Risk Factor Surveillance System. So participants were asked, now thinking about your mental health, which includes stress, depression, and problems with emotions, for how many days during the past 30 days was your mental health not good? Scores of 14 and above indicate the presence of frequent mental health distress, which is used as a proxy for poor mental health. Intimate partner violence was assessed using the Women's Experiences with Battering scale, a standard scale developed to capture the way women perceive violence done to them. Women were asked to think of their current partner, if they had one, or if not, to think of any partner in the past when answering the questions. Scores of 20 or more on the Webb scale indicate a positive screening for intimate partner violence. Behavioral risks were assessed with questions from the dynamics of care assessment. These questions looked at substance abuse, binge drinking, and sexual risk-taking. Participants noted the frequency with which they engaged in these behaviors, ranging from never, not in the last 3 months, and in the last 3 months. So for substance abuse, they were asked if they had ever used any of the following: heroin, crack, amphetamines, ecstasy, crystal meth, or injected drugs. Binge drinking was self-report consumption of 5 or more drinks in one sitting within the last 30 days. Sexual risk behaviors included sex for money and or other goods, sex with injection drug users, sex with someone who is HIV positive, as well as unprotected sex within the last 3 months. An affirmative response to any of these questions was coded as positive for these behaviors. And then a SAVA score was created by summing these dichotomous measures. And so the range for that SAVA score was 0 to 5 for each participant. Covariates included in adjusted models included dichotomous measures of health insurance and education, age, race, employment status, housing status, and continuous years HIV positive. The outcome variable of HIV RNA suppression was also dichotomized into suppressed and not suppressed. The analyses were restricted to women with viral load tests within 90 days of completing the baseline survey. So this gave us a sample of 564 women. We looked at the prevalence of each psychosocial problem. We also used binomial regression to assess the bivariate relationships between each psychosocial problem and viral load suppression, and then used generalized estimating equations accounting for the site clustering effects to look at each single psychosocial problem modeled as the outcome, with the other 4 SAVA-related factors modeled together as predictors to assess clustering, and then also looked at viral load suppression as the outcome, with the SAVA score as the predictor. So our age of participants, you can see that 10% of women were less than 25, 20%, 25 to 34, and then 31% in that 35 to 44 age range, as well as 45 to 54, 9% 55 or older. The average years in our sample of being HIV positive was 8.4 with a standard deviation of 7.6. Just over 67% of women were Black non-Hispanic, and nearly 26% were Hispanic or Latina in the sample. 40% had not graduated from high school or earned a GED. Most women, 56%, were not working. The majority of women, about 65%, either rented or owned their own home, with about a fourth living in someone else's home, 6% in an institution, and 6% on the street or living in a single-room occupancy. And about 31% of the sample had no insurance. So looking at the prevalence of the psychosocial problems, 39% had 14 or more mentally unhealthy days, so we classified that as poor mental health. 54% reported substance use, 9% binge drinking, 27% screened positive for intimate partner violence, 73% screened positive for sexual risk behaviors, and 46% of the sample were virally suppressed. To explore the clustering among the SAVA variables, models were developed for each SAVA variable as the outcome, with the other four modeled together as predictors. And here we adjusted for the covariates, the demographic, sociodemographic covariates. So overall, these findings indicate clustering among the psychosocial variables comprising the SAVA score, with sexual risk-taking and substance abuse having a particularly strong association in the presence of the other factors. Overall, this demonstrated a strong association between the co-occurring issues, which is a criteria of a syndemic. The individual psychosocial problems that were used to construct the SAVA score were associated with lower odds of viral load suppression, but only one variable was statistically significant in the fully adjusted model. Intimate partner violence was associated with lower rates of viral load suppression with an odds ratio of 0.62. The models demonstrated overall low predictive value of these variables when evaluated individually, though the associations were all in the expected direction. Here we have the distribution of participant SAVA scores. So this was when we added up the dichotomized values. So 11% had none. And then you can see 29% had one of the psychosocial issues, 27% with two, 23% with three, and then that dropped to 9% and 1% respectively for 4 and 5. So in general, the percent of the study sample that was virally suppressed decreased as the number of psychosocial problems increased, suggesting more psychosocial problems were associated with lower suppression scores. Close to 50% of the women reporting 0, 1, or 2 of the issues were virally suppressed, compared to 41%, 28, and 33 for those reporting 3, 4, or 5 psychosocial problems, respectively. Interestingly, the proportion of women virally suppressed was around 50% for those with 0, 1, or 2 psychosocial problems, before dropping significantly for the 30% of women with SAVA scores of 3 or more. Therefore, the additive effect appears to plateau when 3 or more of the psychosocial problems are present, suggesting a threshold beyond which an increasing proportion of women have poor clinical outcomes. The relationship highlighted in the prior figure was replicated in the statistical models. Higher values on the SAVA score were associated with lower odds of viral load suppression among these HIV-positive women of color. Following adjustment for the covariates of categorical race, ethnicity, employment, housing, insurance, education, and the continuous years of HIV infection, the SAVA score was associated with decreased viral load suppression with an odds ratio of 0.81 among these women. There was a high prevalence of psychosocial problems, and a clustering was evident among this population, providing evidence of as well as an additive effect of the factors on viral suppression, providing evidence of a syndemic effect, that is, psychosocial issues combining to increase the disease burden in this population. Women of color are a hugely diverse group, of course, including multiple racial and ethnic identities. The findings here are most applicable to African American and Black women and Latinas, as other women of color were not sufficiently represented. But even within these racial or ethnic groups, important variation and heterogeneity exists. The SAVA-related factors may interact in unique ways to affect viral load suppression across racial and ethnic groups due to differing historical, cultural, and socio-environmental contexts. So future research should incorporate these cross-cultural comparisons of the causes and consequences of the SAVA syndemic to inform culturally specific models, deepen our conceptual understanding, and ultimately inform interventions. The research reported here is limited in several ways. This analysis utilized cross-sectional data, precluding assessment of directionality of the association. The sample consisted of women who had not been regularly engaged to care prior to the viral load, prior to the baseline survey, but they had a viral load test within 90 days, so it's not necessarily representative of all women at all stages of the HIV continuum of care. We didn't control for the prescription of antiretroviral medications, to which adherence is necessary for viral suppression. This is because, according to our conceptual model, engagement in HIV care, including ARV prescription and adherence, are on the causal pathway from psychosocial status to viral suppression, and adjusting for causal intermediates is inappropriate and would result in an over-adjustment bias. However, we did include the length of time that women had been diagnosed with HIV. We hope to continue these analyses, including additional types of violence in addition to IPV, such as childhood sexual abuse, which was not assessed in this study. But this is the first study, to our knowledge, to demonstrate a syndemic effect on viral suppression among HIV-positive women in the United States. Given the importance of HIV viral suppression to achieve a generation without AIDS, comprehensive interventions that more effectively address these intersecting issues of substance abuse, violence, HIV, and mental health problems are needed, which must include systemic work to target the underlying conditions perpetuating health inequities in the U.S. along racial, ethnic, and socioeconomic lines. All right, thank you.